Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Coming up on the podcast today, I'm talking to GP Dr Rik Fijten and consultant hepatologist Dr Kosh Agarwal about the NHS in England's drive to eliminate hepatitis C. The World Health Organisation is aiming to eliminate hepatitis C globally by 2030, and NHS England wants England to become the first country to do this, with a target to achieve this aim by next year. In this conversation, Rik and Kosh explains how the NHS is doing against this target and the important role that general practice has to play in helping to eliminate hepatitis C. Rik explains his role as a GP hepatitis C champion, setting out what GPs and their teams can do in their practices to contribute to this work. And Kosh discusses what advances in treatment mean for patients and the transformative impact they've had. He also talks about whether the approach NHS England has used for hepatitis C could work for other conditions. I found this such a fascinating conversation, and it's a really positive story about a successful national initiative that's making a huge difference, so I hope you enjoy listening to it as well. I'm delighted to be joined on the podcast now by Dr Rik Fijten and Dr Kosh Agarwal to talk about how the NHS England is getting on in its bid to eliminate hepatitis C and the role of general practice as part of this. Rik is a GP and the hepatitis C GP clinical champion for Bexley in South East London, and Kosh is a consultant hepatologist and transplant physician at King's College Hospital in London. Thank you both for coming on the podcast.
Thanks for having us.
Thank you very much, Emma.
The World Health Organisation is aiming to eliminate hepatitis C globally by 2030, and NHS England has set a target to become the first country to do this, with a goal of doing it by next year, by 2025. So that's quite an ambitious target. But before we come on to talk a little bit more about how we might achieve that target, I thought it was worth looking at some of the stats and figures. So Rik, what are the current stats and figures about where we're at with hepatitis C?
Thanks, Emma. I think, as you mentioned there, it was an ambitious target set by NHS England, but one that we're working towards very successfully. So in terms of stats related to hepatitis C, so current estimates suggest that the prevalence is roughly about 0.17% in the UK population. But I think what's more relevant and more interesting for listeners is some of the stats related to the successes of the elimination programme thus far. What we've seen is there's been a significant reduction in prevalence for hepatitis C, so up to 61%. There's been about 35% reduction in hepatitis C related deaths and about a 50% reduction in hepatitis C related liver transplants, which is a huge success. Another real success story is the fact that 80% of treatment delivered to those living with hepatitis C has been delivered to those in the most deprived 50% of the population. So that really links in with the core 20+5 work that the NHS England have been doing. So far, it's been fantastic and a real success, but lots of work still left to do.
Rik has given us some of the key figures, but this is a stunning national programme that's been running now for just over 5 years. So the Department of Health committed to reaching these WHO guidance that is really built around reducing mortality, increasing diagnosis and more treatment. And certainly this program, which is about testing patients, screening them, and then delivering treatments to them and having an innovative drug deal that was a national contract, has really been very successful. So as a transplant specialist, we do not see now patients coming for liver transplantation with hepatitis C. It's actually much more important for Rik and his colleagues, and this is the message for this podcast, to really keep testing for hepatitis C. So aside from COVID, I think we are pretty much on track to be one of the first countries in the world to eliminate or control hepatitis C as per those WHO guidance. So yeah, really stunning program that is worth talking about and making sure all your listenership are aware of.
It's a really good success story. It's really nice to be able to talk about something very positive that's going on in the NHS as well, isn't it? So when we talk about eliminating hepatitis C, what do we mean by that? What does the WHO say you have to do to basically achieve that elimination? And what are the targets that NHS England has committed towards?
Good question. So the WHO guidance is about elimination. I think eradication is a similar word, but eradication means getting rid of every single individual with hepatitis C. And I think that is probably not feasible. We'll always have some small proportion of patients with hepatitis C. There are sort of clear metrics of sort of surveillance that we would need to commit and achieve to using public health and UKHSA. But the WHO guidance per se is about reducing deaths by 65% in both hepatitis C and also in hepatitis B. We mustn't forget hepatitis B, to make sure that 80% of patients are diagnosed, but most importantly, which I left at the end, identifying and diagnosing 90% of patients, which is where the work of Rik and his colleagues and primary care becomes now critically important.
Which groups of people are most likely to be affected by hepatitis C?
The biggest risk factor for hepatitis C is intravenous drug use. Those patients at highest risk. There are lots of other risk factors which we need to be aware of within primary care. Our migrant populations. The prevalence of hepatitis C in the UK is much lower than in other areas, so sub-Saharan Africa, parts of Central Europe and Eastern Europe. Obviously, if you are working in those areas where you have a high number of patients from those countries, it's really important to think about hepatitis C when seeing these people in practice. Other really important risk factors to think about is people who've come in contact with the criminal justice system, sex workers, those suffering from homelessness, and obviously very relevant currently, those that have received a blood transfusion before 1996 with the infected blood inquiry and everything that came with that. It's really important to be aware of it in practice. Lots of risk factors. That's why the elimination programme is fantastic. And the work that we're doing as GP champions is really focused on increasing awareness of the condition and making the primary care workforce mindful of it, getting people thinking about it when they are seeing patients in practice. Because with hepatitis C, the vast majority of people who have this disease will not know they have it. So they will have no symptoms. So from a diagnostic point of view, they won't present with symptoms to a GP or practice nurse. It is about thinking about their risk and offering them opportunistic testing, which, again, there are lots of ways in which we can do that.
I think the infected blood inquiry is critical and is an awful experience for patients. I just want to be clear. It's, I think, 1992 that the UK government started screening blood products, and it was before 1992 that we have these concerns. Rik is completely correct about talking about the majority of patients having lifestyle issues and IV drug uses and a very efficient way of transmission. More and more, we're seeing patients from different ethnic environments and acquiring hepatitis C from different medical environments or treatments in non-sterile areas. But most importantly, the point he made is about the liver and liver disease being generally very asymptomatic. So the liver is an amazing organ. It can take lots of damage without demonstrating any symptoms. And that's why we want to screen for bloodborne viruses, Hep C, Hep B, and HIV, opportunistically to identify these viruses, particularly Hep C in this context, before they cause longer term and decompensated liver disease. So when we have much very efficient treatments that work very well in the early phase of the disease.
The incidence of hepatitis C fell pretty dramatically between 2015 and 2022. Is that because of advances in treatment and the way we identify people?
That is the success of the program, is that we used to have a treatment for hepatitis C, which was pegylated interferon. Pegylated interferon is kind of like chemotherapy. You'd have to have it for a year. You'd have to wait for 6 months afterwards. And the cure rates were between 20 to 30%. So patients really didn't want to come forward for treatment. It was pretty torrid. We did not have treatments that were good enough for patients. Then coming through with the research, and I was involved in some of the clinical trials, we had the licensing of these new drugs called directly acting antivirals that were initially rolled out for those patients with more advanced disease, those who would get the greatest benefit. Then they were rolled out very quickly to all patients with hepatitis C. So actually, we had a huge rump of patients who were diagnosed or who had advanced liver disease or who were needing liver transplants, by the way, and we were able to treat those patients and cure them. And it's been the most transformative part of medicine in my practice over the last 6 years. So I could talk about this forever. The incidence has fell. I think there are some issues with our public health data, but in reality, the success of this English program, because it's NHS England, is that treatment access in all areas has been coupled with much, much more widespread diagnostic and screening practice. So screening more patients and then treating them. So actually, we're towards the end of this program, having had a little bit of a blip because of COVID for all those reasons that we know about. But now this is the hardest bit, because now we have to find those unknown patients or those unknown unknowns, probably most of all in primary care, maybe not as much as some people think, but really cover all the areas. And we may talk about different strategies and initiatives that we are using in health and care justice, in ED practice, in opt-out testing, in drug and alcohol services, in opportunistic testing at every level and in general practice to identify any patients who might not know they have hepatitis C, and then to link them very quickly to a very safe, tolerated, curative therapy that is phenomenal.
Rik, you're a hepatitis C GP champion, and that's a role that's actually part of this NHS England drive to eliminate hepatitis C. What exactly does your role involve day to day?
So I think there's a number of components of my role. As Kosh has mentioned, it's at the heart of what we're trying to do is increase testing. And to be able to do that, we need to make the primary care workforce more aware of this disease through education. So that's a big part of my work as GP champion. So coming on podcasts, providing education to the workforce. We're also that link between the operational delivery network. Across the UK, there are a number of operational delivery networks who coordinate the work of the elimination programme. And we work closely with them to really identify the needs of our local population. So for example, within the area that I work in, Bexley, we've done a lot of work with the drug and alcohol service and homeless charities. We've worked together to deliver opportunistic testing through testing events where we've brought a testing centre into Bexley, which can offer testing to those that are suffering from homelessness, which is a really, really effective way of engaging with people who might be at risk. Another huge part is how we identify those people who might be living with hepatitis C. So getting the workforce to offer this testing when they see people who they might think are at risk. But of course, on a wider scale, we need to think about other ways in which we can do that. And the main ways that we can do that is by running searches on our IT systems to identify those people who might have been coded as having hepatitis C in the past, but perhaps lost to follow-up, so not engaging in treatment, or those who have risk factors for hepatitis C. What the elimination program has done is they've developed a robust search which is embedded on our clinical systems, which we can run at scale to give practices a list of patients who would benefit from a test or who would benefit from a conversation about whether they're engaging with treatment. As GP champion, I support with that work. I support practices to run those searches and then to share those searches with the operational delivery network, who actually do a lot of the hard work, in terms of contacting patients and getting patients tested. So I think that's really, really important because, as you know, across primary and secondary care, we're all very, very stretched at the moment. I think it's important to know actually running this search is very, very straightforward. The rest of the work in terms of engaging with patients doesn't need to be done by the practice. That's where the ODN comes in. And I think that's really, really crucial, actually. They have the time, they have the means, they have the links with the community organisations, charities such as the Hep C Trust to really engage with these patients.
I think hepatitis C is a success story that needs more success, that will now be driven by primary care, just as Rik has talked about, screening and searching to look for those patients who are at risk or who've been diagnosed and never been referred. But most importantly, also, hepatitis C can be a way to bring individuals who are disadvantaged into inclusion health, bringing patients into the models of healthcare that we can offer them and actually giving something tangible to them, because hepatitis C is not just a liver disease. Hepatitis B can have lots of systemic manifestations of tiredness and other symptoms that can be significant but are not easily attributable just to hepatitis C. So for those patients who are outside the sort of standard system of healthcare, it's a really effective way of bringing them in to get them tested, treated, and as a benefit to bring them into healthcare for inclusion health.
You mentioned all those searches there that people have got in their clinical systems. I mean, is there anything else that you think practices can be doing to help with this work?
Yeah, absolutely. I think we have, as part of the elimination program, there's a fantastic self-testing portal that has been created. As Kosh mentioned, a lot of people who may be living with hepatitis C find it difficult to engage with healthcare services. There's still a lot of stigma attached to hepatitis C, and people might not feel comfortable or confident coming forward to speak to someone about their risk and to request a test. So with the introduction of the self-testing portal, this removes some of this difficulty and this barrier. So there's lots of patient-facing resources that practices can access, and we can share the links to those. There's a QR code that patients can scan, takes them to the self-testing portal, and they're sent a home testing kit, which they can do themselves. It's all confidential. If that test does come back positive, their local ODN will contact them and they will provide the support they need to get them into treatment. So I think that's really fantastic. I think, again, it's that education, it making the workforce aware that this is relevant to practice nowadays. So you don't need to organise it yourself in practice, or you can organise this test very simply through a standard blood test that you might be doing for an unrelated condition. So, if you're doing your chronic disease monitoring, if you think that person is at risk, offer the test. The other thing to think about is more innovative ways of increasing testing. So with your NHS health checks or your new patient checks, thinking about your patient population and whether you can include this and a screen for other bloodborne viruses, such as Kosh said, hepatitis B, HIV. These are other things that you can be doing. And I think what's really important, and the power that we have at primary care level, is if we can work within our PCNs, particularly, and think about our local population needs and develop strategies that we can use to identify people who might be at risk, and working with the ODN, who are real great support, you can really make a difference.
So Kosh, how does your role fit with this? Where does the hospitals and secondary care come in with all of this? And how important is it that there's a joined up approach between primary and secondary care?
Of course, it needs to be joined up, but actually I'm a minor player now in this program, and primary and community care, I think, as we've already kind of highlighted, are really the main drivers. So as you said, the ODN stands for Operational Delivery Network, and actually there are 22 in England, and they were nationally specialist commissioned. And so this is a national specially commissioned program. It's not been devolved to ICBs and won't be, because this is so important that we achieve elimination. So we are commissioned to be responsible for all aspects of testing and treatment throughout a defined geographical area. And currently, which is why I look a bit haggard, we cover southeast London and the whole of the geography of Kent. So that's about 10% of England. So we hold the responsibility, and resource comes with that. And we are charged to make sure that resource serves its core purpose, which is supporting and identifying initiatives and delivering data and outputs, because we have to evidence elimination. I think that's the concern, is that we need to have that evidence that we're getting to those kind of criteria that we talked about at the beginning. But we have to try and balance all the different competing issues and move our initiatives. Right now, it's easy because most of treatment occurs out of hospital. Actually, Rik and his colleagues, we're very, very lucky to have really impressive individuals as GP champions. The last 400-meter runner hurdle kind of racers who are going to bring us home to identify any of the last tranche of patients that aren't known about, so that we can treat them in an environment that works for them. So I'm a coordinator, much less a treater of patients with hepatitis C.
The other part of this programme, though, it's not just primary care, is it? We're aiming to find cases of hepatitis C. There are other initiatives, I think you briefly touched on them, Kosh, earlier, in emergency departments, maternity care and prisons, for example. Can you explain a little bit about what else is going on with identifying the cases?
The two main ones I'm going to focus on are ED testing, which is a massive success, but again, demonstrating the need for sustainability and resources. So on the back of very successful Elton John Foundation funding in a few sites in London, NHS England commissioned, I think in 2022, in areas of higher prevalence, really taking the HIV data, opt-out screening for bloodborne viruses of HIV, hepatitis C, and hepatitis B. There's lots of information in the EDs, and individuals, unless they opted out, would automatically, through the lab-based systems, have a hierarchy of HIV, Hep C, and Hep B tested. And in London, that has been a phenomenal success. In South London, have diagnosed about 200 new patients with HIV. We have found the majority of those patients are known and aside to those, but lost to follow-up. But in hepatitis C, we've identified, I think, 170 brand new patients that we did not know about. And then the second piece to talk about is antenatal screening. So the numbers may be slow, but that's a very useful point of contact where we are obviously seeing pregnant women. And that's a point that we can actually identify and screen patients, and likewise their offspring if they're positive. And that is something that's now gritting in and really trying to be done in a more comprehensive way. And obviously going into prisons and testing and screening those who are coming in and offering treatment to those who are positive. This has been a rolling program nationally for now 4 or 5 years. We're actually achieving elimination metrics in several prison environments. So that's very well established. So it's really building ED testing is exciting. Building the equivalent of opt-out testing in primary care would be phenomenal. And Rik's colleagues have got some ideas about that. But for example, in London, building in the antenatal screening, but always linking in with primary care and really making primary care and the workforce in primary care very well aware around what the opportunities are of identifying hepatitis C, because it's a very simple treatment and very effective treatment now.
Rik, I also want to ask, is prevention part of this strategy as well? And what do we need to be doing about preventing cases of hepatitis C?
I believe as my role as GP champion, prevention doesn't sit underneath most of what I do, but I think it's really, really important. Again, it goes back to making the workforce aware, also working with public health. As we mentioned, thinking about those risk factors. So particularly intravenous drug use, making sure there are safe places for people, needle exchange, all these types of things I think are really important. So absolutely prevention is key. I think it sits under public health. As a GP champion, I'm there to support with that work and identify needs of our local population so that we can ensure those that are at risk, we reduce their risk.
Rik is right. I mean, his focus is predominantly education, I'd say. Of course, other strategies, and we're not lacking in policies and strategies across the NHS, but the national drug strategy and public health local strategies for prevention of transmission remain very, very critical as well. These are bloodborne viruses, but actually hepatitis C is not phenomenally an infectious virus compared to, say, hepatitis B. But absolutely identifying, screening first-degree relatives, referring and accessing treatment quickly is in itself an act of prevention as well as treatment and cure. But there is a prevention piece for particularly those who may have high-risk activity with IV drug and misuse issues, but that feeds into the drug strategy of clean needles, all of those sorts of elements that we're not directly responsible for, but there is a huge intersectionality with providing that. It is fair to say that those areas are fairly challenged from a resource perspective, and their priorities may be slightly different and are more holistic to Dr. Agarwal's view on we must find patients with hepatitis C, but they are very willing to do what they can do. So that's another part of my role with Rik in trying to bring everyone along.
Taking together all of the things we've just been talking about, how likely is it that we're going to reach this 2025 target in England, do you think? It's not very long away now, is it?
I would say that we are not going to achieve the 2025 metrics for WHO elimination, and there's a very clear reason for that, because we lost 2 and a bit years within COVID, and actually the mortality data in non-cirrhotic patients was going down very favorably, but went up during COVID and is now coming back. I think the other piece is, without being too downbeat before I'm upbeat, is that we're lacking hard data regarding exactly where we are at with regard to our achievement of what the metrics are for elimination. We've achieved the metrics for mortality. I think we're achieving close to the metrics for testing, but I'm not sure in all environments we're achieving the metrics of the numbers of diagnosed getting to treatment at this moment in time. Because of that unknown group of patients, we don't have a clear set of the data to help us understand, well, how big are the unknown unknowns, because they're unknown, if that makes sense. So I'm very confident that NHS England are going to continue to support this programme. I'm confident that this is a very good news story from an inclusion health and delivery of Hep C treatment perspective. And I think we will do this before 2030 easily. But you're completely correct that 2025 is not very long away. And I think it's the data that now my colleagues in the national team are really keen to try and corral and get clearer.
You mentioned the infected blood inquiry earlier, Rik, and, that final report of that came out not so long ago. And obviously, hepatitis C is one of the conditions that patients contracted as a result of that scandal. Are we still seeing the effects of that in patients today? Should GPs be doing more to kind of pick up on patients who might have been infected by that scandal, do you think?
It's hugely relevant when we're seeing patients. It's being cognizant of that as a GP, or if you are working in primary care, and where appropriate, signposting those patients to testing. Absolutely. So it links into everything that we've discussed so far. The ability to test now is so easy and so accessible that it's something that, we definitely need to be offering and supporting those that might have been affected.
Absolutely, yes. We should be making sure and making reparation for anyone who was infected by hepatitis C, or in the context of contaminated blood products. I don't want to make any comments about the inquiry and the background around it, but there's no doubt the human side of this has been utterly tragic with regard to individuals being infected and not knowing that they were being infected, and the risks associated with it. Having said that, and being slightly controversial, we absolutely should be identifying those patients, but I like to treat all hepatitis C patients the same. I have that balance between these patients have had harm, but all of the patients with hepatitis C should be getting access to treatment, and everyone should be getting access to treatment as quickly as possible. But there's no doubt that the proportion of patients who have acquired hepatitis C through infected blood and HIV, it has to be said, I think the majority of them have been diagnosed. I think it's completely tragic. And the next question you're going to ask is whether that has bumped up awareness, that recent infected blood inquiry report. It has, actually. And in the web testing portal that Rik alluded to, I think there was a very significant increase in the number of uptake of tests compared to previous months.
Is there anything else that you think as a key thing that GPs need to be aware of when it comes to hepatitis C?
What I would say is that we can make a huge difference as GPs. It's important to think about it. As we've said, people who are living with it will not have symptoms. So it's about offering testing, ensuring that in your practice, patients are made aware that testing is available and the self-testing portal exists. And actually, we can really make a difference. And that would be my take-home message.
What about you, Kosh?
I've got 2 take-home messages. So number 1, obviously always agreeing with Rik. That's not part of my 2. For primary care colleagues, there are a lot of things and initiatives where people are very challenged and very busy, and you think, well, why are we doing this? And this is not one of those. This is a real success for patients, and is a real success for the NHS and delivery of this. So anyone who is still committed to the health of the nation and health of the patients in front of them, this is a very, very simple and productive opportunity to do good by simply just thinking about testing for someone for viral hepatitis if they have risk factors, or even just testing them if they've never been tested. The second big point, which is the real cut-through point, as a transplant doctor, we used to transplant about 30% of our patients for hepatitis C for liver transplants at King's. We now consent patients who need renal transplants and heart transplants and lung transplants for hepatitis C positive organs so that they can have their transplant, because we're so confident in the treatments afterwards, even though they're immunosuppressed, even though they've had a transplant, that we can get rid of their hepatitis C. So we now deliberately give people hep C organs when they're available, because the treatments are just so bloody good. And so if we find the patients and we give them the tablets and they take the tablets, they get cured. And that's a really good thing.
It is an amazing story. It must have been so rewarding to have worked on all of this, both of you. But I mean, Kosh in particular, working on all of these new treatments that have come through. It must be amazing seeing how your practice has changed when you have patients coming into your clinics.
Rik is so young and fresh-faced, and I'm really old and haggard. So I've been around for a long time. You can hear it in my voice. It is so transformative. When, we had our meeting today and someone said, oh, this gentleman had a liver cancer related to hepatitis C and alcohol, and our training and resident staff, they don't see patients now with hepatitis C. Whereas we used to see a significant proportion of our patients having hepatitis C that used to come back after a transplant and be more aggressive. So we're almost taking this for granted because these treatments are just so good. And the NHS really did an innovative drug deal, and the pharma companies put money into these initiatives. But the real message is to think about liver disease, to think about hepatitis C, and to diagnose and screen, because if we don't diagnose everyone, we can't treat them. And the treatment bit is really, really easy. And actually, we should have people like Rik prescribing and treating if they're comfortable with me in the background, because the drugs are so easy to use these days. So it is really fun and exciting, but the challenge is really, can we bring this home now? And what does this mean for the wider picture of liver disease in the community and the identification of liver conditions early?
Do you think this sort of approach, is it likely that NHS England might look at this for other disease areas as well, because it's been so successful?
So the operational delivery network for hepatitis C was the prototype operational delivery network for a condition that has now been taken on by several other therapy areas. So it has worked. It is nationally specialist commissioned, so it's an anomaly now because it's so important. But for me, in what's left of my career, I'd say we want to bring home elimination for hepatitis C. In London, we want to then start to bring in a sort of a community-based but specialist oversight, diagnostically driven view of hepatitis B, and then move towards the identification of liver disease alongside that, so we can identify liver disease early, because most of the resources and most of the illness associated with liver disease occur when you have decompensated liver disease. And liver transplants are very, very expensive, and a very expensive way to treat end-stage liver disease. And most of them, hepatitis C is curable and treatable. Hepatitis B, you can treat and suppress, or you can vaccinate against. And fatty liver disease, there are new medications coming on board, and lifestyle issues, and alcohol, likewise with lifestyle. These are all preventable or treatable as long as we can identify them early. So I can see a very big role for primary care morphing into a community liver type network. And the last piece to say for this, Emma, is that we have heard that liver disease is going to get a NHSE transformation status, which I don't think comes with a lot of money, but comes with a degree of focus that starts to allow us to talk about these networks and involve the community and primary care. And so it's got to be very integrated in the way we've delivered in Hep C. So yeah, I think it's going to be fun.
We talk a lot about integrated care, but I think this is a perfect example of how care can be integrated between different sectors of the healthcare service. And yeah, it definitely should be an example of how it can be delivered at scale, and it can really work.
Well, it's been great talking to both of you. It's really good to have something so positive to talk about on the podcast as well. So thank you both very much.
Thanks so much.
Yeah, thanks for having us. We really enjoyed it. Thank you.
Well, that's it for this week. Thanks for listening, and thanks so much to Rik and Kosh for speaking to me. I'll be back next week with Nick for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice on our website at GPonline.com.